Okay, sorry about that. That's what I don't like about using my cell phone trying to do this. I have not found a better way as of yet. I'm again so frustrated. All that recording I did on Spinal Cord using this new thing called Screencastify that's connected to Google Drive. And again, when I uploaded the link, all it is a PowerPoint. It took me 4 hours recording over that PowerPoint because, again, doing these PowerPoints is just like you guys in class, and it takes the same amount of time, if not more. Even more time when I'm breaking it into parts and editing it and uploading it as a voiceover PowerPoint in CAMS. But I am yet working on the best method possible for us to deliver these PowerPoints, because I know going forward to leadership, we will be continuing with this same particular method. So I got a call. It cut my video off, kind of cut my voice off in that previous little section. That little first spread is only a few minutes. I don't know if I'll have to probably break this down every 30 minutes or so. So it might be more than one part, so that it don't take all day uploading like the last YouTube video. I went over an hour and it took all day for that video to upload and allow me to get the hyperlink in order to send it to you. But as I was saying, this particular picture is an angiography that's demonstrating that fusiform abdominal aortic aneurysm. The arrows there are showing where there is calcification of the aortic wall and extension of the aneurysm into the common iliac arteries. Now, this is the aortic aneurysms that they may involve in the aortic arch, and they have thoracic and abdominal aortas as well. 3/4 of aortic aneurysms occur in the abdominal aorta, 1/4 in the thoracic aorta. Most occur below the renal arteries, and the larger the aneurysm, the greater the risk for rupture. Now, as far as the etiology is concerned, the dilated aortic wall becomes lined with thrombi that can embolize, which leads to acute ischemic symptoms in the actual distal branches. Causes, the most common cause of descending triple A's. That's what the abdominal aortic aneurysm is usually called, a triple A. The most common cause is atherosclerosis. Male gender and tobacco use are the major risk factors for triple A's of atherosclerotic origin. Other risk factors include the presence of coronary artery or peripheral artery disease, hypertension, and high cholesterol. Other risk factors include age, male gender, which we had already mentioned, coronary artery disease, family history, we mentioned the high cholesterol, any other peripheral vascular disease, carotid artery disease, a previous stroke, and we mentioned tobacco use, and obesity is also one of the risk factors. Tobacco use is the most modifiable risk factor, as well as weight, being overweight or obese, because those are things that we really can change. We can get on diets to lose weight, and we can go to smoking cessation classes to help stop smoking. Now, the genetic link with aortic aneurysms, the family tendency is actually related to a number of congenital abnormalities. Examples include these that are listed: the bicuspid aortic valve, co-articulation of the aorta, Turner syndrome, autosomal dominant polycystic kidney disease, as well as specific collagen defects like the Ehlers-Danlos syndrome. And I'm not familiar with that, honestly. And it also talks about premature breakdown of vascular elastic tissue in the Loeys-Dietz syndrome and Marfan syndrome. And of those three, I am familiar with Marfan syndrome. You do have two basic classifications for aortic aneurysm. It's either a true or a false aneurysm. This is a true versus false. A is a true fusiform abdominal aortic aneurysm, and B is a true saccular aortic aneurysm. C is a false aneurysm, or what we call a pseudoaneurysm, and D is what happens when aortic dissection actually occurs. Now, true aneurysm. With the true aneurysm, the wall of the artery actually forms the aneurysm, and at least one vessel layer remains intact. True aneurysms will further subdivide, and they become fusiform, which is circumferential, relatively uniform in shape. And then you have the saccular, which is pouch-like with a narrow neck, connecting bulge to one side of the arterial wall. Now, our classifications: under false aneurysms, they may result from trauma or infection, or may occur after peripheral artery bypass graft surgery at the site of the graft to artery anastomosis, where they actually connect the site to the graft. And they also may result from arterial leakage after removal of a cannula, like the lower extremity arterial catheter or the intra-aortic balloon pump device. Thoracic aortic aneurysm, TAA, is often asymptomatic. Most common manifestation of a TAA is deep, diffuse chest pain, and the pain may extend into the interscapular area. In the ascending aorta and aortic arch aneurysms, they cause angina from decreased blood flow to the coronary arteries, transient ischemic attacks, which is what we call a TIA, from decreased blood flow to the carotid arteries, and coughing, shortness of breath, hoarseness, and or dysphagia, which is difficulty swallowing, and that is due to the pressure on the laryngeal nerve. Now, with the abdominal aortic aneurysm, is often asymptomatic, frequently detected on a routine physical exam. A pulsatile mass is in the periumbilical area, slightly to the left of the midline, that may be present. You also may be able to auscultate a bruit over the aneurysm, and physical findings are sometimes more difficult to detect in those patients who are obese. Now, with the AAA, compression of any nearby anatomic structures and nerves may cause symptoms such as the back pain, the epigastric discomfort, altered bowel elimination, and intermittent caudation. Occasionally, aneurysms spontaneously embolize plaque, causing what they call the blue toe syndrome, and that appears as a patchy mottling of the feet and toes in the presence of a palpable pedal pulse. Rupture of an aneurysm is a more serious complication, and it is most likely to occur in people who smoke. That rupture is into the retroperitoneal space. Bleeding may be tamponaded by surrounding structures, thus preventing exquination, exsanguination, and death. These people complain of severe back pain, and they may or may not have the back flank ecchymosis, which what we call the Gray-Turner syndrome. The patient who reaches the hospital will be in hypovolemic shock with tachycardia. As we know, anytime we have a drop in cardiac output, the first compensatory mechanism is tachycardia. And when we are hypotensive, that causes decreased tissue perfusion. And if that is not corrected, we end up with necrosis of the tissue. These people also have pale, clammy skin, a decreased urine output, altered level of consciousness, and abdominal tenderness. I know my mother acted restless and confused, and at the time all this was going on, I couldn't really put the picture together, but that confusion was due to a lack of oxygen to the brain because of the lack in blood flow, because the aorta had been leaking for maybe about a week. So in a situation like this, simultaneous resuscitation and immediate surgical repair are necessary. When it comes to x-ray, first you want to do that EKG or ECG to rule out whether these people are having an MI. And since the thoracic aneurysm or dissection symptoms can mimic angina, that's one of the reasons why you want to get the ECG first. And then they do a chest x-ray, which will show a mediastinal silhouette and any abnormal widening of the thoracic aorta. And as far as the abdomen, it may show calcification within the wall of the AAA. They also can do echocardiography, which assists the diagnosis of aortic valve insufficiency, and they also can do ultrasonography, which is an ultrasound pretty much, using which is useful for actually screening of the aneurysm, and it also can monitor the size of the aneurysm. The CT scan they can do, it's the most accurate test to determine anterior to posterior length, cross-sectional diameter, the presence of a thrombi, and the best type of surgical repair for the aneurysm. And you also can do an MRI as well, and that is utilized to diagnose and assess the location and severity of the aneurysm. We proceed with angiography, where that's useful, especially if you have a suprarenal or thoracic abdominal aneurysm. If either of those are suspected, angiography will be a good source for that. And with the angiography, it is anatomic mapping of the aortic system using contrast. It's not a reliable method for determining the diameter or the length though, and it can provide, again, accurate information about involvement of any intestinal, renal, or distal vessels. And that's why I said it is really useful if you have a suprarenal or the thoracic abdominal aneurysm. You can use angiography. As far as our interprofessional care, you know, we always want to do a careful review of body systems in order to identify any comorbidities, especially anything involving the lung, hearts, or kidney, because they may influence the patient's actual surgical risk. So our goal is actually to prevent rupture of that aneurysm. Early detection and treatment is imperative, and once that aneurysm is detected, studies must be done to determine the size and location. Now, a small aneurysm is anything that is 4 to 5.4 centimeters in size. They can do conservative therapy, and that usually consists of risk factor modification, such as tobacco cessation, decreasing the blood pressure, optimizing the lipid profile, and annual monitoring of the aneurysm size using ultrasound, CT, or MRI. Growth rates may be lowered using beta adrenergic blocking agents like propranolol, which is Inderal, ACE inhibitors, which is our lisinopril or captopril, and then our angiotensin 2 receptor blockers like losartan, and our statin drugs like simvastatin, and antibiotic like doxycycline. Monitoring by ultrasound every 2 to 3 years is recommended for patients with AAAs that are smaller than 4 centimeters in diameter. A 5.5 centimeter size aneurysm is the threshold for actual repair. So surgical intervention may occur sooner if the patient has a genetic disorder like those Marfan disease and that Ehlers-Danlos syndrome. The aneurysm expands rapidly, and if it becomes symptomatic or if the risk of rupture is high, those are some of the things we take into consideration when we are looking at surgical repair. Again, we have to do a careful review of body systems because that is necessary to identify any comorbidities. Again, especially paying close attention to the lungs, hearts, and kidneys because they affect the patient's surgical risk, and correction of existing carotid or coronary artery blockages may be needed before they can actually do the aneurysm repair. For elective surgery, the patient needs to be well hydrated, and any electrolyte coagulation or hematocrit abnormalities are also corrected preoperatively. Surgical technique that they use, they do the open aneurysm repair, abbreviated the OAR, and incising disease segment of the aorta, and they also can do removal of an intraluminal thrombus or plaque as part of the surgical technique. They also, with the OAR procedure, they actually insert a synthetic graft, and that graft consists of Dacron or polytetrafluoroethylene, PTFE, the suturing of a native aortic wall around the graft. They do that as a form of protection, and on the next slide it's going to show these particular techniques. Now, with the saccular aneurysm, it may be possible to excise only the bulbous lesion and repairing the artery by primary closure, which is only suturing the artery together, or by application of an autogenous or synthetic patch graft. And again, they'll show that on this next slide. So there are the techniques in the surgical repair of that aneurysm. A is incising the aneurysmal sac. B is insertion of that synthetic graft. And C is suturing the native aortic wall over the synthetic graft. So all of these are techniques that can be utilized in surgical repair of the aneurysm. Now, if you go back to chapter 30, it does discuss about autotransfusion, and in the aortic aneurysm, autotransfusion reduces the need for blood transfusion during surgery. So the AAA resection, it requires cross clamping of the aorta, proximal and distal to the aneurysm, and that procedure can be completed in 30 to 45 minutes, and the clamps are removed and blood flow to the lower extremities are restored. So with these AAA resections, if the cross clamp have to be applied above the renal arteries, adequate renal perfusion after clamp removal should be determined before they actually close up, just in case they have to go back in there and do some other type of repair. So again, they need to confirm actual renal perfusion when they are doing a procedure and the cross clamp is above the renal artery, and they need to check that before they actually close the patient up. And the risk of post-operative renal complication, such as acute renal injury, that increases significantly if the patient who have surgical repair of the AAA above the level of the renal artery. So they have a high potential to develop renal complications post-operatively. As far as the endovascular graft procedure, this is a minimally invasive procedure, and it's abbreviated EVAR, the EVAR. It is an alternative to the conventional or OAR procedure that we just talked about. It involves placement of sutureless aortic graft into the abdominal aorta inside the aneurysm. And again, as I said, it is a minimally invasive procedure, and it's done actually through a cut down of the femoral artery. The endovascular graft procedure. The grafts are made of various materials, such as Dacron cylinder, consisting of several sections, and they are supported with multiple rings of flexible wire. They will show this little procedure as they did the other one on the next slide. The surface, it's delivered through a sheath in order to predetermine the point when they're doing this procedure. So the EVAR procedure, this is what it looks like. So it's bifurcated endovascular stent grafting of the aneurysm, and bifurcated just meaning it's two branched. In the A picture, the insertion of a woven polyester tube, which is the graft, is covered by a tubular metal web, which is the stent. In B, the stent graft is inserted through a large blood vessel, which is usually the femoral artery, using a delivery catheter, and the catheter is positioned below the renal arteries in the area of the aneurysm. In illustration C, the stent graft is slowly released or deployed into the blood vessel, and when the stent comes in contact with the blood vessel, it expands to a preset size. In illustration D, a second stent graft can be inserted in the contralateral or opposite vessel if necessary. And finally, in E, it shows fully deployed bifurcated stent graft. So that's the end of the procedure, step by step, and what it looks like after it's been completed. So with the endovascular graft procedure, the graft, again, is delivered through a femoral artery catheter, is deployed against the vessel wall by balloon inflation, and is anchored to a vessel by a series of small hooks. With the endovascular graft procedure, we want to include the iliofemoral vessels in the criteria, because that will allow for safe graft insertion, and vessels of sufficient length and width to support the graft. So as it shows here, blood flows through the graft, preventing expansion of the aneurysm. The aneurysm wall will begin to shrink over time, and it must meet strict eligibility criteria or requirements to or in order to be a candidate of this particular procedure. The benefits of doing the endovascular graft procedure over the OAR procedure is you have decreased anesthesia and operative time. You have a smaller blood loss. You have a decrease in morbidity and mortality rate. You have a more rapid resumption of physical activity, a shortened hospital stay, quicker recovery, and the patients have a higher satisfaction, and there is a reduction in overall cost as well. Now, complications of that procedure, the most common complication is the endo leak, where you have seepage of blood back into the old aneurysm, and this may be due to an inadequate seal at either the graft end or a tear through the graft fabric, or leakage between the overlapping graft segments, and it may require what they call coil embolization, where they insert these beads for hemostasis in order to stabilize the process. The endovascular graft procedure also have a potential complication for stent migration, renal artery occlusion, graft thrombosis, incisional site hematoma, as well as infection at that site, and renal artery occlusion that may occur due to stent migration. So that's one of the things that we really have to monitor the patients for post-operatively. And the patients undergoing the EVAR procedure, they also require periodic imaging for the rest of their lives to monitor for an endo leak. They have to document stability of the aneurysm sac and determine the need for any other surgical intervention. So that was something interesting that they had to be monitored for the rest of their lives when you do the EVAR procedure. Now, as far as the intra-abdominal hypertension, abbreviated IAH, persistent IAH reduces blood flow to the viscera, and when you have what they call ACS, it's not acute coronary syndrome, which is what we've been going over. That actually refers to the impaired end organ perfusion, which is caused by the intra-abdominal hypertension, and it results actually in multi-system organ failure. The intra-abdominal hypertension treatment, the goal includes control of situations that lead to intra-abdominal hypertension, conservative measures such as intubation, ventilation, patient positioning, gastric decompression, cautious fluid resuscitation, pain management, and temporary hemofiltration. They are all used to treat this patient. But remember, the treatment goal is to control situations that actually lead to intra-abdominal hypertension. So I am going to end right here and restart the next video with nursing management of these people, and hope that it does not take so long to upload. So I will pick up with our third little session on this particular chapter, and I will start with this slide on nursing management. Thank you.